let's turn to early stage non-small cell lung cancer, where we have a new approval of chemo combined with Opdivo immunotherapy based on this trial called Checkmate 816 that compared chemo alone to chemo with Opdivo in patients with stage 1B to 3A disease. And 2/3 of these patients had stage 3 disease. The results were very encouraging, very favorable, showing the chance of major shrinkage being 4-fold higher if you got immunotherapy. That's based on imaging, and more than 10-fold higher if you looked under the microscope at the time of surgery. We saw some additional data at ASCO that essentially showed that the more effective the therapy, there was a breakdown of what we call complete pathologic response, or pathologic complete response rather. So no living cancer under the microscope. That is looking at it in a binary way. It's either is there some or is there not? And 76% of patients still had some. And they don't do as well in terms of the chance of the cancer coming back. These data showed that the less living cancer you had, the better you did. And so I think that's important. We also saw, presented from the same investigator from Spain, Dr. Florencio, a very similarly designed trial called Nadim 2, also giving chemo or chemo with Opdivo before surgery, did give post-operative Opdivo for patients. And this trial also allowed patients with a little more advanced disease, now stage 3A versus and 3B. This is a different category of staging, but I think that there's going to be, from the enthusiasm of this, more patients with questionable surgical or resectability. What they saw was that a significant fraction of patients, didn't go on to surgery, as shown in the chart on the right, that 69% had surgery from chemo. So essentially, some patients, maybe a regrettable fraction, were not able to successfully do surgery. And I think one of the worst outcomes we could have is a patient go to surgery, be opened up, have the side effects of that, but not have all of the cancer removed. That's a problem. What we also saw was, as with the Checkmate 816 trial, giving Opdivo with chemo was associated with a much higher rate of completely eradicating the cancer, but it depended on what the PD-L1 expression was. This is in keeping with so much of what we've seen. So I just wanted to ask, Gilberto, where are you left with for this? Your enthusiasm for preoperative, your thoughts on, what happens if you don't get a pathologic complete response, and does the level of PD-L1 modulate your enthusiasm?
So I'm left with way more questions than answers. Okay. This is certainly a very interesting approach. Giving 3 cycles of chemotherapy and immunotherapy makes sense to me from a financial perspective. And of course, we don't want always, or we mostly don't want to make decisions based on that alone. But this is a lot cheaper than going for surgery first and then giving adjuvant chemo for 4 cycles and then immunotherapy for a year if you're PD-L1 positive, which is the current standard of care in the US. Of course, with the approval of this regimen, we can use it, and we are using it more often. So our surgeons are very enthusiastic about this. They want us to start doing this for patients that are beyond the staging that we would consider it, which is maybe single station and 2, or patients that have tumors bigger than 4 centimeters or have positive Hylar nodes. So that's the big question. How much does this change? How much more sense does it make to do all these treatments pre-op versus after surgery? And when we look at different diseases, when we look at lung cancer itself in the chemotherapy alone era, we were never able to prove that giving something in the neoadjuvant setting improves overall survival compared to giving the same something in the adjuvant setting. You have situations in which it makes perfect sense. If you have rectal cancer, you have better local control. If you have breast cancer, you're able to do smaller surgeries. But I'm not necessarily sure that this is the case in lung cancer yet. So I think that it's still a toss-up of what the standard is. Our surgeons are so enthusiastic about this that we are doing this more and more. And then when patients come to me, the question is, okay, can I stratify based on their PD-L1 and their response what we should do next? Should we just stop at the chemo plus immunotherapy? Should we complete a year of immunotherapy? Should we go to 2 years of immunotherapy? Should we give one more cycle of chemo? Should we give cisplatin if patients got only carboplatin in the neoadjuvant setting? So it definitely brings me more questions than answers.
Now, Jarushka, you've been close to the scene. You've been part of a lot of these. Where do you come out in the mishmash of results here? And are you seeing patients who are kind of square peg round hole for the OR?
Yeah, I think, this is just the start of the avalanche of data of neoadjuvant. And I think we all should brace ourselves as the new data emerge. I must say, clearly I'm biased though. As you said, I participated in, and put a lot of patients on that original study. 816 is very much a Hopkins-led study. So I feel very familiar with this approach. I think some of the questions which Gilberto brings up that are very relevant is which patients of early stage non-small cell lung cancer are going to benefit from this the most? And in particular in this study, what defines resectability in stage 3 disease? It's interesting, all our major questions in lung cancer are being revived in the stage 3 setting. What is resectable or not? Do we do molecular testing or not? What defines the optimum treatment duration? All of these things I think will be very unique in stage 3. And again, I think if you looked at the table baseline characteristics, it's anywhere from a small tumor with bulky nodes to a big tumor and no nodes here. So really that heterogeneity in the population is, I think, hopefully is going to keep us in business for many years, trying to untangle this.
And the fact is that we are talking about, PD-L1 is different, but the health of the patient, the location of the disease, the patterns, the heterogeneity of stage 3 or even resectable in general is enormous. So points very well taken. And you also make the point that we're going to have a lot more to talk about as new data emerge. I want to thank you both for great discussions about this and other things we've covered. Thanks so much for taking the time today.